All right, we are going to go through the final exam review session for Heme 1. So it's going to be a little different on this one in that I don't have an overall PowerPoint prepared with just like big takeaways. So I'm just going to give some insights, and then I do have a couple of PowerPoints that I will be sending out. So after I record this, I like to record it first and then send them out afterwards on this one. So you should be getting those with the link if you're not in here. So on the exam itself, it's around 73 points, but I'm going to be changing that. There was one question, I was just looking through it. There is one question I have to change, and so it's probably going to go up in points. It might be a little bit more than 73. It might be, I don't know, like 78 or 79, maybe even 80. So I just have to fix one question. Otherwise, they are all multiple choice except this one question. So there will be one question that is not multiple choice. That'll be more of like an essay or short answer question. Otherwise, the rest are multiple choice. So I'm just going to fix that one, and then it should be good to go for you guys. So for the exam itself, my kind of hints and tips on how to study is definitely go back and listen to the exam review recordings. So I would first hit those before anything else, re-listen to those, get to know any content in there, anything that you're probably struggling with the most, go study that first, and then move on to other kind of content. Make sure you look at your lab review questions still. I think those are awesome questions. Sometimes I use those questions, sometimes I don't, but they're still really good questions. Your calculations, I think you guys do need to revisit calculations. I know that calculations don't always stick with me. So make sure that you hit that one chapter we had on calculations. I can't remember what week it was exactly in, but I think it was chapter 15. So there will be a lot of calculations on there. So things like hemocytometer calculation, your MCV, MCH, MCHC, your retic count, absolute reticulocyte count, corrected white counts, and corrected reticulocyte counts. All of those are going to be possible calculations. Also, your iron saturation, your transferrin saturation, that's out of chapter 11. There was one calculation on chapter 11 on transferrin saturation. That's also good as well. The only calculation I am not putting on the exam is RPI. We are not going to play with RPI on the final exam, so don't worry about that one. But the rest of them are very applicable. I might have even missed mentioning a couple. Still know like rule of three. Rule of three was in there as well. Absolute counts on how to calculate an absolute cell count. So all of that's very applicable. All right, so with that being said, I'm going to jump into some of the PowerPoints I have here just to kind of go through. First and foremost, I have these two PowerPoints. One is going to look like this. The other looks just like it, but it's the answer key. This is a PowerPoint of 77 slides of questions. So it's all these questions, and some do have calculations in these questions for you to practice. So after we are done here, I am going to send you both this one and the answer key for it so that you can go through and practice these questions on your own. If you struggle with a question, that's probably telling you you don't know that content area. Go back and study that area from your PowerPoint, from your chapter, whatever it might be. So mark down which questions you struggle with, because that's probably the content that you don't know as well. So I'm going to send you guys that. And then the other thing I have here is a big PowerPoint on pictures, because on your lab practical, and I think I sent this out at one point a couple weeks ago or a week or two ago, on your lab practical you will be given images to identify, especially poikilocytes and inclusions, and then you have to name not only the poikilocyte and inclusion, but what disease they might be found in. You just have to name one disease with each. And then for the inclusion, you will also have to tell me what it's made of. So this is good practice for that, different pictures. You might get pictures of just white blood cells, immature red cells, poikilocytes, malaria, babesia. So those could be pictures on your lab practical that you will be asked to do. So we will kind of go through that too. All right, for the final exam review questions, I'm just going to start going through some of these. I am not going to read through 77 slides because I think that would get to be really long and boring for you guys, because I know that if I send both this and the answer key, you can do it as well and study on your own. But I want to go through it and kind of start you on it at least. Again, if you're listening to this as a recording, just pause it, figure out your answer yourself, and then restart it to hear if you were right. That way you can also kind of go along with me. So first question here is erythrocytes that vary in size from the normal 6 to 8 micrometers are described as exhibiting. So this one, anything that's varying in size would be anisocytosis. So letter A would be the answer. And again, anisocytosis is the one that's indicated by the RDW results on a CBC finding. And I think a lot of you have this down now. So we will see some of these other words here soon. So anisocytosis, variation in size. Which of the following is the preferable site for bone marrow aspiration and biopsy? And this would be for adults, it would be iliac crest. So letter A there, iliac crest. For children, it was typically like the front of the tibia. All right, so one of our first calculations would be mean cell volume. So which of the following is the right formula for mean cell volume? So mean cell volume always involves the hematocrit with the red cell count times 10. I know that this is written a little differently. We have been typically writing it as hematocrit times 10 divided by red cell count. Either way you write it, it works. It'll still calculate the same. It's just written a little bit differently. So letter B there is the right answer for MCV. And again, you need to know not only the calculation, but the reference range. MCV is 80 to 100 femtoliters. So as always, anything less than 80 is microcytic. It's going to tell us it's small size. Anything greater than 100 is macrocytic or large in size. So of course, anything in between is normal. I think you guys have done really good at starting to apply those terms on your differentials in lab, on some of the case studies that we've been doing as assignments. So hopefully that's getting easier and easier for you with that. All right. Which term describes the change in shape of erythrocytes on a stain smear? So shape is going to be poikilocytosis. So letter A is going to be our change in shape. Actually, I do want to just go through the rest of these. So we had already said poikilocytosis was the shape. We know anisocytosis from the previous question was varying in size. Hypochromia means you have a low MCHC. That's where you have very little hemoglobin concentration, so you'll see an enlarged central pallor to those cells under the microscope. Because they have very little hemoglobin, so there's little red, there's lots of white, lots of central pallor. And then polychromasia is a word that indicates there's increased retics on your smear. And we know they're reticulocytes because they're slightly blue-gray in color due to the remnant RNA in them. All right, so here's one of the first calculations. Calculate the MCHC using the following information. So again, MCHC is going to be your hemoglobin times 100 divided by hematocrit. So once you do that, you should come up with one of the answers. I'm going to let you guys do that on your own. You'll have the answer key given to you so you can look at it then. I'm not going to take time right now. Same with manual hemocytometer counts. This one is asking specifically for a hemocytometer count on a white cell count, and I gave you the formula down at the bottom as a reminder. Remember, there's two different ways you can do it. It's whatever one you like. Just pick one of them to remember. So, and then you kind of go ahead and look through this. Now, this one is a little tricky. That darn white cell one is the one that you have to move that decimal in 3 places to change it back to the times 10 to the 9th per liter instead of times 10 to the 12th. So when you do this calculation, I believe originally you're going to get, how much do you get again? I think you get 400, and you got to move it in 3 spots to get 0.4 as your answer. You know what? Let's do this one together to make sure that I am correct on what I'm talking about here. So I don't want to lead you astray. So basically, when we look at this, we're going to do the number of cells. Now, if they gave you 2 different cell counts, you're going to average them. So if they were to say 40 on one side, 45 on the other, you average it first and then use that number. In this case, they just gave us 1. It was 36. So you take 36 times the dilution factor. So our dilution was 1 to 10. So our dilution factor is 10. And we're going to take that times the depth. Now, depth is always 10 when you use this formula. The original depth is 0.1, but again, when you flip it to this way, it's 10 on the top. So we got that answer. Now we're going to divide that by area, which is how many squares. So in this case, they counted 9 squares, so we're going to divide that by 9. So yeah, you get 400. Now, when you look over here, like 400 is not an answer. And that's because this is in a different unit. And so to get it to the 9th, times 10 to the 9th, move that decimal in 3 spots. So when I move it over 3 spots, I get 0.4, letter A. That's the answer. So that should be good for you. It should be pretty simple. I don't think I have any too tricky on the exam at all. So if you just know your formula and how to calculate it, you should be just fine. All right, so here's another hemocytometer one you can practice. Here, this is starting on a little bit of inclusions and things. Which of the following erythrocyte inclusions can be visualized with supravital stain, but not with right stain? So the one that can only be seen out of these choices with supravital is Heme bodies. So if I were to show you a picture on the lab practical of Heme bodies and I said only using supravital, then I would ask, okay, name me what it's made of. What is a Heme body made of? And you should say denatured hemoglobin. Or if you just want to say hemoglobin, that works. I always put the HE of Heme and the HE of hemoglobin together to remember. I'm like, he. It sounds stupid, I know. But that's how I remember it. The HE in Heme and the HE in hemoglobin, that's how I know they're made of each other. So that is made of denatured hemoglobin. And then I might say, well, name me a disease that you would find Heme bodies in. So then you could say G6PD deficiency, because that's a really big one that we commonly see Heme bodies in. So that would be, you just have to memorize one disease with each thing. Don't have to try to remember them all, just one with each, and that should be good for you. So that would be the answer there. Okay. So this is asking red cell indices obtained on a patient are as follows. So this is making you know your reference ranges for those. So again, MCV is normally between 80 to 100. So 88 is normal, so that's normocytic. So it's either C or D. MCH, we don't really apply a term to that, so we can kind of skip that now. And then MCHC is 34. The normal reference range for that is 32 to 36. So that is a normal result. So letter C, it's a normocytic, normochromic patient. So that's how you do that. All right, this one, what staining method is used most frequently to stain and count reticulocytes? So you guys got to do this in lab. You're still going to need to know how to perform this for your lab practical. So make sure that you remember how to do that reticulocyte count from lab in your lab practical. So the stain that you guys used should have been some form of supravital stain. I'm sure most of you probably use new methylene blue. That's probably the most common one that we tend to go to. So new methylene blue is a type of supravital stain. We've asked that question on a couple different assignments. I can remember at least 2 assignments that I had that question on. All right, a correction is necessary for white blood cell counts when nucleated red cells are seen because, and the reason we always have to correct for a white cell count when you have nucleated red cells present is the nucleated red cells are counted as leukocytes, so letter C. So that analyzer will falsely count the number of nucleated red cells because they think they are white cells. So you got to fix that. So there is that equation. Please know that calculation for how to correct the white count. All right, using a culture counter analyzer, an increased RDW should correlate with what? So I said this earlier in the very beginning slide. Increased RDW tells us we have anisocytosis present, so increased variation in sizes. All right, given the following values, which set of red cell indices suggests spherocytosis? So this is kind of a little bit of extra, it's like an additional step to it of thinking about, okay, what values do we see with spherocytes? And the one thing that we always discuss seeing with spherocytes, and it's one of the only times we see it, is a high MCHC. That's very rare to have a high MCHC, and one of the only times we do is with the spherocytes. So right away, I would go over to the MCHC column and look for that. Anytime you're discussing a question on spherocytes, if they're giving you indices, look for that MCHC to be high. So when I think of a high MCHC, it has to be above 36, and the only one matching that would be letter C, that 39% there. So that would be indicating spherocytosis. Which of the following is considered a normal hemoglobin? So this is going all the way back to chapter 10. So carboxy, that's not normal. Let's revisit what that means. Carboxy was due to carbon monoxide poisoning. So remember, your blood has that classic cherry red color. Hemoglobin, if it has a choice between oxygen and carbon monoxide, it's always going to pick the carbon monoxide all the time. So that's the problem, is and what causes eventual death to your tissues from not getting oxygen. So carboxyhemoglobin, not normal. Methemoglobin is when iron changes to the ferric 3+ state. Oh. So remember that ferric is icky. We don't want that. You can't find and deliver oxygen the way that you normally should. It won't deliver the oxygen well. So we always want iron in that 2+ ferrous for us state. So anything that's 3+ ferric is icky. That's not good. That is not normal. Sulfhemoglobin is due to different drugs or chemicals that the person might be taking, and that changes. There's not a lot you need to know on that one, but just know it's not a normal hemoglobin. So the only one that's normal is the last one, deoxyhemoglobin. All that means is that the hemoglobin has delivered the oxygen. It's done. It delivered its oxygen, and now it just needs to go and find more. So that's it. That's all it did. It did its job of delivering oxygen. So that is totally normal. So that was a nice revisit to chapter 10. All right, which of the following can shift the hemoglobin oxygen dissociation curve to the right? A lot of people get the hemoglobin oxygen dissociation curve messed up. It's not always easy to remember. So this is that whole thing where if certain things are happening to the patient's body, it might switch the way that we release and bind oxygen, how we play with it, with our hemoglobin. So remember, if that curve should shift to the left, that means that the hemoglobin has a really high affinity for the oxygen. In other words, it loves it. Left loves. It loves it so much, it's not going to give it up. It's going to keep it, and it's going to really not want to deliver it. It's going to really keep it to itself. So the other shift was shift to the right. In that case, it's a low affinity. In other words, it was going to easily release the oxygen, right release. It can't wait to get rid of it. It wants to get it out there and deliver it to the tissues. So now that we know which direction a curve could shift, there are several things that could do it one way or the other. So first off, a high pH, which is known as alkaline, would shift to the left. Low CO2 is going to shift to the left. And when you think of it this way, if you have been through clinical chemistry, this should be easier for you. If you've not been through clinical chemistry, yeah, it's going to be a little trickier. But the way I always like to explain this is CO2 is an acid in our body. It acts like an acid. So if CO2 is acidic, if you have very little, low numbers of CO2, your pH will rise up and become more alkaline because you have very little acid in your body. So that's why the low CO2 and the high pH always go together. If you got little CO2, little acid, your pH is naturally going to become more alkaline. So if you think of it this way, that should help, hopefully. Other things, a low 2,3 BPG. So remember, the whole job of 2,3 BPG is to help oxygen get released and delivered to the tissues. That's 2,3 BPG's job. So if 2,3 BPG helps release oxygen and you have very little of it, it's not going to help it get released. It's going to let it hang on to it instead. And then the other one is finally low temperature. So the lower your body temperature, like the colder you are, the more it's going to hang on to it. All right, so those are the things that will shift it to the left. Now let's discuss the things that shift it to the right. It's basically going to be all the opposites. So a low pH, otherwise known as an acidic acid condition, will shift it to the right. and high CO2. Again, as I described before, CO2 is an acid, so if you have a lot of CO2, a high amount of it, your pH will be acidic. And you should think of it this way. If you have a lot of CO2 in your body, you should naturally want to get more oxygen out there. You should want to release it out there to help compensate and get more oxygen instead of the CO2 out there. So that's why it will shift to the right to easily release that oxygen because it wants to since we have too much CO2 happening. It will also have a high 2,3 BPG since that's the job. Its job is to release the oxygen, so the more of that we have, the easier we can get that oxygen released. And then finally, a high body temperature. If your body is overly warm, it will break the bond between the oxygen and hemoglobin to let it be released. So that will explain that. So if you look at it, I wrote it in a certain way. Just for now, if you can't understand all of the background behind it, memorize it at this point and work on, getting the understanding there as you go. But I always look at it this way. I always remember alkaline has L's in it, so I know that goes with shift to the left. And then I remember if that's a high pH, I know everything else is opposite. And then down here, I know it's all opposite that, I guess, as well. So use whatever you can to help you remember this, because this will help you on a few of those questions. So now that we've discussed that, let's go back to our original question, which is which of the following can shift hemoglobin oxygen dissociation curve to the right? So right release. So we have increase in 2,3 DPG, same thing here, as high 2,3 BPG. Yep, that definitely will shift it to the right. We have acidosis. Well, we said that here, an acidic pH will shift it to the right. That's true. Hypoxia. That means that your tissues are low in oxygen. Of course, if a patient is really anemic or hypoxic, you're going to naturally shift your curve to the right to get more oxygen out there. So the answer on this one is all of it. All three of those will shift that curve to the right. All right, so I know that can be a complex subject. Just do your best. Okay, which of the following organs is responsible for the pitting process? This would be your spleen. At any point, your blood is traveling through the spleen. Macrophages are in there looking for inclusions or things that they can pit out or remove. Spherocytes differ from normal red cells in all of the following ways, except, so yes, they have a decreased surface to volume. Yes, they have no central pallor. And yes, they have decreased resistance to saline, meaning they can't fill up any more than what they already have in there. They'll burst. That's that whole osmotic fragility thing. So the only thing that's not true is they are not deformable. Remember, they're rigid. They get stuck. They hemolyze as a result. So letter D would be the answer because that is not true of spherocytes and the others are. Which of the following is not associated with hereditary spherocytosis? So again, we're looking for the one thing that's not part of it. So we do see increased fragility, we do see that high MCHC, and again, spherocytes are a sign of extravascular because they are hemolyzing and occurring in the spleen where they get stuck in those small spaces. So the thing that's not true would be C, intra. The other three are true of it. All right, so you can see we have several questions on, another question here on spherocyte. You can do that on your own. Here's a question on P and H. P and H always confuses people. Let's do this question. Which of the following is most true of paroxysmal nocturnal hemoglobinuria, otherwise known as PNH? This was the one that we discussed in the PowerPoint that had hereditary spherocytosis in it, hereditary elliptocytosis, all those diseases that a lot of them were hereditary. And then when I got to this one, I specifically said, this is not hereditary. This is an acquired red cell membrane defect. So letter A would be your answer. PNH is an acquired membrane defect. At some point in your life, you pick it up. It is not inherited. So that would be the answer there, letter A. We also went through the MAHAs. HUS was a type of MAHA. We see that here. It says HUS is characterized by all the following except. Well, if it's part of a hemolytic process, we said some of the signs of HUS is it does have a low platelet count. Because it's an intravascular hemolysis, we will see hemoglobinuria. Remember, anything intravascular, you should see hemoglobinuria, hemoglobinemia, hemosideruria with it. Yes, there is hemorrhaging going on. This is the one that goes with bloody diarrhea from eating E. coli 0157 or Shigella, food poisoning like undercooked beef and stuff. So there is some bloody diarrhea hemorrhaging happening. So the one that's not true is reticulocytopenia. Remember, anytime we have hemolysis, your reticulocyte count is elevated, is high. You should have reticulocytosis. So that's always an indicator that there's some sort of hemolytic process happening and your bone marrow is trying to put out new cells for it. So we know that this can't be true because this is a hemolytic process, so it should have been a high retic count. All right, this was from our last chapter that we just had in week 10. There was a chart in that PowerPoint when I lectured through, and I said, absolutely know this chart. If you know anything else out of that chapter, this is on that chart, so you can kind of go revisit that. I'm going to have you guys look that up. All right, this one. All of the following are associated with hemolytic anemia except. Let's go over this one because hemolysis is quite in-depth for people. So I just said that the 3 classic signs of an intravascular hemolytic anemia are hemoglobinuria, hemoglobinemia, and hemosideruria, which isn't even on here. So we know that both these two are definitely always a part of an intravascular hemolytic anemia. So I know we're just talking about hemolytic anemia in general, but they are definitely always a part of that. Methemoglobinemia, that's the one that probably tricks people up the most. When we discuss the intravascular pathway, there was always proteins involved in saving that hemoglobin to try to prevent it from being filtered. When albumin would bind the hemoglobin to save it, it would change it into methemoglobin on purpose. Like with the whole binding and attachment, it actually changed it. So we do see methemoglobinemia in the blood because the albumin has bound it, changed it to help prevent and save it from being filtered through the kidneys. The one that's not true is haptoglobin. Remember, haptoglobin is another protein that binds hemoglobin, brings it to the liver, but when doing so, it gets depleted in the process. So as a result, we always see decreased haptoglobin with hemolysis. So this would not be true. All right, autoimmune hemolytic anemia. We just kind of discussed this last week in week 10. There was warm reactive autoimmune, and on that chart, that magical chart I said to know out of week 10, for warm reactive autoimmune, it said that it was an extravascular process. So knowing that it's an extravascular hemolytic anemia, what is characteristic of extravascular? And that would be your spherocytes. So again, spherocytic red cells would be the answer. Okay, bite cells. Bite cells are basically cells that have gone through the spleen and the macrophage has taken a bite out of them because it's removing an inclusion. So there was an inclusion in there that the macrophage bit out, and then you're left with a bite cell. Kind of looks like Pac-Man, if people are familiar with the Pac-Man game. Is that old school? Maybe it is, but you get it. So that's kind of what a bite cell looks like. That's an indicator that, yes, that there's been inclusions removed. So now that we think of that, let's look at our choices. Which one of these have we always discussed that there's an inclusion involved with? Well, we've never even discussed Rh null, so don't even answer that. If you've never even heard of that in the whole hematology quarter, it's not the answer. We haven't discussed this one either, not the answer. But we did discuss this earlier, just here in this review even, and remember, this is the one that we see lots of Heinz bodies in. So those are little inclusions, and yes, when the macrophage bites the Heinz body out, it leaves it looking as a bite cell. So bite cells are commonly seen with G6PD deficiency as a result. All right, the morphological classification of anemias is based on which of the following? So again, we classify all of our anemias according to MCV size, which is part of the red blood cell indices. So remember, they're microcytic, normocytic, or macrocytic. So those are all part of the indices. Moving on to some bone marrow failure. Which of the following is a common finding in aplastic anemia? So aplastic anemia means bone marrow failure, essentially, without cells. If you are without cells, you should have pancytopenia occurring. Every cell line should be low. That's what the word pancytopenia means, is all three cell lines, red cell, white cell, platelets, are all low. That's definitely a very common finding in aplastic anemia. All right, so some more. These are more bone marrow failures out of that same chapter, so you can look at that. Again, MAHA here, so you can look at that. Spherocytes again, reticulocytosis, another one out of that chain, one of those chapters we just went through. Iron deficiency, we haven't hit this yet. Let's look at this real quick. All of the following are characteristic findings in a patient with iron deficiency anemia except. So let's think back. Iron deficiency was one of the first anemias we learned. It was chapter 20, I believe. It was definitely a microcytic hypochromic anemia, so that's true. Letter A is good. Weirdly enough, it does have an elevated platelet count. I don't know if we really said that at the time, but yes, iron deficiency does have an increased platelet count. They're not totally sure why. There's some thoughts and theories, but it is commonly to see increased platelets with iron deficiency. So that's true. Letter C, that's where we get our hang up. Remember, TIBC was that test that really separated iron deficiency from anemia of chronic inflammation. So in iron deficiency, there is lots of room on that transferrin protein for iron because they're low in it. They don't have iron to bind to it. So if there is lots of iron binding capacity, which is TIBC, then it should be an increased results. So your TIBC in iron deficiency is increased because it has lots of room for iron since there's no iron available. All right, so another one, iron deficiency may be distinguished from anemia of chronic inflammation or chronic disease. Again, that's that TIBC. So in iron deficiency, the TIBC is high. In anemia of chronic inflammation, the TIBC is low. So another one on iron, I'll let you kind of get through that. More iron. This is calculating your indices again, so make sure you know those calculations. Another one on iron deficiency and anemia of chronic inflammation. All right, now we're getting into megaloblastic, which is another anemia we did learn. So this one says, which morphological classification is characteristic of megaloblastic anemia? The nice thing is the name itself, mega, tells you the cells are going to be big. You know that they're going to be macrocytic, and typically they are normochromic. So that would be the ideal setting. Yes, once in a great while they might become hypo, but the better fit is normochromic. So they're definitely macrocytic though. They're very large red cells. All right, Schilling test. There was a little bit of talk on Schilling. I know that there's a lab review question on Schilling, and it was a really good one that I always wanted you to know. And essentially the purpose of knowing the Schilling was basically it's used to diagnose pernicious anemia. That's all I want you to associate is the link to pernicious anemia diagnosis. So look back at that lab review question. There's one on there. I know that out of those multiple choice questions that you complete in lab. Okay. All of the following characteristics of megaloblastic anemia except. So let's go through this. Actually, first, let me describe what's wrong in megaloblastic in case you don't remember. So remember, the deal in megaloblastic anemia is either they are deficient in vitamin B12, or they are deficient in folate. So they are missing at least one of those, maybe both if the situation's really bad. Why that's important is that vitamin B12 and folate are needed for DNA synthesis. So if they are missing one of these, then you impact the DNA synthesis of the cells. So you have inappropriate DNA synthesis for your cells as they're trying to get made in the bone marrow. As a result, you don't have cells coming out. So you will definitely see pancytopenia, that low cell line counts on all three cell lines, because they're all getting impacted from the lack of DNA synthesis happening. The hypersegmented neutrophils, that was the only time we ever talked about that was linked with megaloblastic. That is a very classic finding in this anemia is these hypersegmented neutrophils in which the nucleus is 6 or more lobes to it. And then as we just discussed, mega, they're big cells. We'll definitely see macrocytic red cells. So the only one that's not true is the retic count. Again, if you can't make DNA, you're not going to make reticulocytes either. So those should be a low retic count. It's not going to be high because they're not making cells at all. So that is the one that's the answer. All right, so more calculations. This is putting test results with the disease that we just kind of went through, more megaloblastic. So I'm going to let you guys kind of do this on your own and look at the answer key for help. Again, if you get the answer wrong and you can't figure out why, go back to your lecture PowerPoints, recordings, you know, or you can email me and ask me, or we could set up something to go over it together if you want. So I want you guys to dig into this and just try your best, see how you do. And again, if you start seeing you're getting a topic wrong quite a bit, that's probably a topic you don't understand well. And that's where I would really focus starting to study. So go through these PowerPoints, answer the questions. There's 77 slides of lovely questions for you to do. So you can do that. I will email that with the key for you. And then the other thing here is make sure you keep knowing your pictures. I know I emailed this out to you already, but we will go through it here a little bit together so you can kind of get the gist of what I look for. So if I were to give you a picture like this, I'm looking at what is this white cell here. So hopefully on your practical you would identify it as a lymphocyte. So again, we know it's a lymphocyte, nice round nucleus, very little cytoplasm visible. So that's typical lymphocyte look. So this one, hopefully you said segmented neutrophil. It's got lobed segments, pinker cytoplasm. Real quick, I just want to point out, this is one of my favorite pictures because the nucleus looks like E.T. There's its head and the body. I don't know, maybe you guys haven't seen E.T. All right. This picture, the arrow is pointing at the cell it wants. So this one, hopefully you guys are saying reactive lymphocyte, where it's got the cytoplasm starting to extend around the surrounding red cells. That is a really key sign of a reactive lymphocyte when that cytoplasm starts to wrap around the cells and it kind of gets that basophilic tinge to it. So reactive lymph. Now, maybe I will ask you what disease have we discussed that you see reactive lymphocytes in. And we probably have only discussed this really one chapter, so you're going to have to look for it. But infectious mono, we see a lot of reactive lymphocytes in infectious mono. So that I would keep in mind. All right, hopefully the bright orange-red granules gave this one away as an eosinophil, so bright red orange granules. This one has the dark purple granules, and this would be a basophil. It's always fun when you can get one of those. Here we have a monocyte. I know it's a monocyte because the nucleus is slightly indented. It's usually got an indent somewhere. Lots of cytoplasm visible, and then the chromatin inside that nucleus is a little bit lighter, patchier looking. Those are all classic findings of a monocyte. These have a nice blue-gray tint to them, so these would be reticulocytes. So that blue-gray coloring to them kind of identifies them more as a reticulocyte. This is another basophil, so you can see the dark purple granules kind of covering over the entire cell. Here we have another monocyte, so indented nucleus. You got your cytoplasm visible. It totally is fine to have vacuoles seen in monocytes. That's typical. So you do see those vacuoles there. Another monocyte again, so indented nucleus, very lacy chromatin, very patchy on the inside there. Again, that's very classic to have that nucleus be pretty patchy chromatin instead of very condensed. So monocyte. This is the biggest cell in the bone marrow, so this would be a megakaryocyte. All these little things coming off are platelets. So again, we make platelets off the cytoplasm of the megakaryocyte. Oh, our first shape. So this is an acanthocyte. We know it's an acanthocyte because it has the uneven projections to it. And then the next question on the lab practical is if you were getting an acanthocyte is name a disease that you see it in. So easiest one probably to remember for this would be liver disease. Perfect. Liver disease or any sort of lipid disorder. It's seen a lot with lipid disorders, so that would work for me. Remember, you guys did that whole study guide on poikilocytes, and I tried to add in some additional diseases as I saw they were missing to it. Really get to know that study guide. There was a reason for that. All right, so this one is pointing to the inclusion. Because there's several inclusions there clustered, that is usually indicating Pappenheimer bodies. So Pappenheimer bodies are typically, there's never just always one, there's usually several in a red cell together. So I would ask you, okay, what's a Pappenheimer body made of? And hopefully you should say iron. And then what's a disease that we would see it in? And so these are commonly seen in post-treatment for iron deficiency. So if they've been given extra iron for their iron deficiency, they would result in Pappenheimer bodies. So that would be a disease you could list. All right, here we have basophilic stippling. What is it made of? It's made of RNA, or you could say ribosomes. Either one work. And disease, the easiest one would be lead poisoning. Another basophil. This one's really dark. Some people get kind of goofed up on this because you can't see the granules as much individually, but they are definitely, it's a dark purple granulated cell, so it's a basophil. This would be a segmented neutrophil. Here we have both of those are reactive lymphocytes. Monocyte, indented nucleus there with lots of cytoplasm, so that's a monocyte. So we're looking at this kind of one in the center here. This is an orthochromic normoblast. It has been a long time since we've talked the red cell line. Be sure you still know those pictures from chapter 8. So chapter 8 was the red cell line, and we learned the different stages of the red cells. You do still need to know that. So the orthochromic normoblast is the stage, the last stage to have the nucleus. The nucleus is very, very condensed chromatin, very dark. In fact, we usually call it pycnotic, P-Y-K-N-O-T-I-C, pycnotic, for how condensed and dark it is. So that would be, if you look at the cell, it's the same size as the red cells almost around it. It's getting close to the same size. So you know it's a red cell because it's about the same size. The cytoplasm is starting to get that pink look to it. So that's all very key information. So orthochromic normoblast. Here we have a segmented neutrophil. Red-orange granules tells us it's an eosinophil. This one is pointing to this little guy up here. That's just a platelet. So again, platelets are just granular, no nucleus. Make sure you go back and revisit chapter 13 because you need to know the granules that are inside the platelet and what they have for inside the granules. Also, the other thing I do want to point out with this picture in the center with that neutrophil, those platelets that are right next to it kind of circling around, that is what we call platelet satelitosis. Remember, there's a way to fix that, and you should know that. So if you see this, when it goes through an analyzer, the analyzer doesn't count all those platelets separately. It counts this whole thing as one cell. As a result, your platelet count is skewed. It's not correct. So to fix it, you would redraw the patient in a sodium citrate light blue top tube, rerun the platelet counts, and multiply it by 1.1, and that would give you a more accurate platelet count. Both of these pictures are band neutrophils. Again, in order to draw the band, you want to see a nice UC shape. It shouldn't be any lobes or any little strings. I mean, it should be one nice big band, I guess you would say. Here, that's an orthochromic normoblast again. Very, very condensed nucleus there, really dark looking. And again, it's about the same size as the red cells around it already. Segmented neutrophil, eosinophil with the bright red-orange granules. This is a hemoglobin C crystal. Again, that was off of that poikilocyte study guide. So it's that rod shape, hemoglobin C crystal. If I asked you for a disease, it's simply hemoglobin C disease. So that's pretty easy for the disease. This is a lymphocyte, nice round nucleus, takes up almost the entire cell with very little cytoplasm. That is a Cabot ring. So again, Cabot rings look like kind of a figure 8, as you can see here inside the red cell. So you need to know what it's made of. It's made up of a mitotic spindle. And then disease, a really good disease you could say is pernicious anemia. This would be a lymphocyte, again, round nucleus, little cytoplasm. Oh, this is from week 9. We have it here. So hopefully going by this Maltese cross or tetrad look, you should know this as Babesia. We have another neutrophil. Actually, there's 2 neutrophils in that picture. Both of these are reactive lymphocytes. They're starting to wrap around the red cells there. Oh, I think we had this picture earlier. So that's that basophil again. This is just a close-up, zoomed-in look of a megakaryocyte nucleus. The rest of the cell is just completely cytoplasm, but the nucleus is multi-lobed like this. If this picture throws you off, you can ignore it. This would be a monocyte, again, indented nucleus, more cytoplasm visible. All right, we have another poikilocyte. This one is a keratocyte, or you could say helmet cell. So the helmet cell looks like a helmet if you put it on somebody's head there. So disease, this would be any intravascular hemolytic anemia. So intravascular hemolytic anemia is like MAHA, which are the HUS, TTP, DAC, all of that kind of stuff works for this. This is again coming out of week 9. This is malaria. Specifically need to identify it as the species. So it's Plasmodium falciparum. And I know it's Plasmodium falciparum because again it's that banana shape or crescent shaped gametocyte. We just had this on our case study assignment, so hopefully that's fresh in your mind. I would call this a band neutrophil. All right, so this one, their arrow's pointing there. Very large cell. It's very dark blue cytoplasm, and then the 3 little lighter round areas inside the nucleus are nucleoli. All of that tells us this is a really immature cell. You could just call it a blast cell. This is actually pronormoblast to be specific, so it's the blast cell. The pronormoblast is in the red cell line, but you could just say blast to indicate how immature it is with those nucleoli. All right, now the arrow has moved over here. This is another cell in the red blood cell line. This one is identifiable, again, because of the chromatin inside the nucleus this is the one I always call checkerboard. So the chromatin is very clumped, and then there's a light patch, and then clumped, and then another light patch, and then clumped, and so on. So that's that checkerboard look. The cytoplasm is gray in color. It's getting closer to being lighter, but it's still gray. So all of that goes into identifying it as a polychromatic normoblast. So polychromatic normoblast for this one. And the other thing you should know about that is the polychromatic normoblast is the last stage in the red cell line to undergo mitosis. After that stage, there's no more mitosis. So it's the last stage in the red cell line to undergo mitosis. Both of those, again, are reactive lymphocytes. Here we have malaria again, and specifically you can identify this as Plasmodium falciparum, and the reason being there is 2 chromatin dots in the ring. All the other Plasmodium only will have 1 chromatin dot in their ring stage, but this one can have 2, so it would be Plasmodium falciparum. Here we have a spherocyte, nice round ball, no central pallor. So disease, easiest disease would be hereditary spherocytosis. That's an easy one. Otherwise, any extravascular hemolytic anemia. That's a target cell, otherwise known as a codocyte. That one goes along with a ton of stuff. It can be seen in thalassemias, iron deficiency anemia, sickle cell anemia, liver disease. So, you know, the list kind of goes on and on. There's quite a few things for that. That is a lymphocyte, nice round nucleus, very little cytoplasm. Oh, this one, I do not have this on the lab practical. I forgot that this was on here, but this is a plasma cell. So a plasma cell is usually only found in the bone marrow. Once in a while we can see it show up in the blood due to a disease, but typically just in the bone marrow. And we know it's a plasma cell because, one, it's extremely basophilic in color, very, very dark blue stained. The other thing is this nucleus always is eccentric, meaning it sits off to one side, so it'll always sit to one side of it. So the only thing that you need to remember is plasma cells and B lymphocytes both make antibodies. So a B lymphocyte can differentiate and turn into a plasma cell, but both of them make antibodies. So that I do want you to remember. That is actually a giant platelet. I'm wondering if some of you probably have seen maybe a giant platelet under one of your dips yet. They're kind of neat. It's amazing how big those little platelets can get. And we know it's a giant platelet because there's no nucleus. It's just all cytoplasm. That I would consider possibly a hyper-segmented neutrophil. So let's lobe count. We know it's a segmented, but let's make sure we count the lobes. So we have 1, 2, 3, 4. It looks like there might be 2 here, 5, 6, because it looks like one's over top the other. So if that's the case, there's 6. That would definitely be a hyper-segmented neutrophil. So the other thing is, I could ask you, what disease would you see this with? And then you should say megaloblastic anemia. All right, so that kind of gives you some gist. Now, there's lots more inclusions, more poikilocytes that weren't on here, but you have that study guide that you guys did for a reason. Get to know those things, the diseases, what they're made of, you know, that kind of deal. So you kind of have the gist of what to expect a little bit on that lab practical. The other thing is, on your written final exam, there might be a question on there about a poikilocyte or an inclusion, because we have been talking about them. So it can be both on the written final exam and the lab practical. So do get to know those items. If you guys have any questions about the final, about anything from the PowerPoints that I'm going to send you, whatever it might be, please feel free to reach out. Otherwise, best of luck in studying, and I will talk to you guys soon. Thanks.